Hyperprolactinemia. Hyperprolactinemia is the most common pituitary hormone hypersecretion syndrome in both men and women. Familial pituitary tumor syndrome. I think we will check this out later. So, prolactin secreting pituitary or adenomas, that is prolactinomas, are the most common cause of prolactin level more than 200. Okay, so most common pituitary hypersecretion disorder is hyperprolactinemia. उसका भी most common cause is prolactinoma. Less pronounced prolactin elevation is also seen with microprolactinomas, but is more commonly caused by drugs, pituitary stalk compression, hypothyroid, and renal failure. So I'm just striking this out. Let us go to the etiology of hyperprolactinemia. One is increase physiological hypersecretion will be seen in pregnancy, lactation, chest wall stimulation, sleep, stress, and it was earlier mentioned after acute MI also. Okay. Then hypothalamic pituitary stalk damage because of any tumors like craniopharyngioma, supracellular pituitary mass, meningioma, dysgerminoma, metastasis, anticella, lymphocytic hypophysitis, adenoma with the stalk, compression, granulomas, Rut cases, irradiation, and trauma causing pituitary tract section or supracellular surgery. So main this we know, trauma can easy to remember, any surgical stalk resection or stalk section due to trauma. Then there are tumors, craniopharyngiomas, supracellular pituitary mass, any meningioma, dysgerminoma, metastasis, empty-cella, lymphocytic hypophysitis, adenoma with stalk, any compression, granuloma, Rut cases, irradiation. Then it can be because of the pituitary hypersecretion secondary to prolactinoma and acromegaly. Yes, because acromegaly means there will be increase in TRH. Systemic disorders, chronic renal failure, hypothyroid also there will be increase in TSH, stimulating this thing, cirrhosis, pseudocytosis, and epileptic seizures. Drug induced hypersecretion this is important. Drug induced any dopamine receptor blockers, because dopamine was inhibitory, so if you block it, anti-inhibitory action. So atypical antipsychotics like risperidone, phenothiazine, chlorpromazine, butyrophenones, haloperidol, thiazanthines, and metoclopramide. Okay, and of course this is D2 receptor. Dopamine synthesis inhibitors will be alpha-methyl-dopa, catecholamine depleters, reserpines, opiates, H2 antagonists, cimetidine, ranitidine, imipramines, amitriptylines, SSRI, fluoxetine. Then calcium channel blocker, verapamil, estrogen, and thyrotropin releasing hormone. Because if estrogens are high, so estrogen releasing hormone will be raised. Okay. Go through it once again. Okay. So note that hyperprolactinemia more than 200 microgram is almost invariably indicative of prolactin secreting pituitary adenoma, and physiology causes hypothyroid and drug induced hyperprolactinemia should be excluded. मतलब सबसे first, other than prolactinoma, hypothyroid, physiological of course, and drug induced. These are main. Trauma, section, all these are less common causes. Now, pregnancy and lactation are important physiological causes of hyperprolactinemia. I will mark only which is not was covered in the table. Sleep-associated hyperprolactinemia, marking the sleep-associated hyperprolactinemia reverts to normal within an hour of awakening. Nipple stimulation and sexual orgasm may increase prolactin. Chest wall stimulation or trauma induces chest surgery and herpes zoster. I will just add it here. Chest surgery. Okay. They will invoke the reflex suckling arc, resulting in hyperprolactinemia. Chronic renal failure causes increase in PRL because of the decrease in peripheral clearance. Okay. Primary hypothyroidism is associated with mild hyperprolactinemia because of compensatory TRH secretion, this I mentioned. Mutation of the PRL receptor is a rare cause of hyperprolactinemia. So just chronic renal failure, where was that? Chronic renal failure is because of decreasing clearance, peripheral clearance. Lesion of the hypothalamic pituitary that disrupt the hypothalamic dopamine synthesis, portal delivery, laparoscopic responses are associated with hyperprolactinemia. Thus, hypothalamic tumor cyst infiltrative radiation-induced damage cause elevated PRL. So these are generally in the range of 30 to 100. So I will just mark it 30 to 100 microgram per liter. Whereas adenoma, prolactinoma will be more than 200. Mark it with a different color. Okay. The plurihormonal adenomas may hypersecrete urine, pituitary masses, non-functioning pituitary tumor may compress the pituitary stalk. Okay. Drug-induced inhibition has been mentioned. Thus, antipsychotic and antidepressants. I'm marking this. Antipsychotic and antidepressants are relatively a common cause of mild hyperprolactinemia. Most patients receiving risperidone. So, risperidone have an elevated problem. Methyl-dopa inhibits dopamine synthesis. Verapamil blocks dopamine release. Yes, calcium channel blockers block dopamine release. Hormonal engineering estrogen. Okay, I'm not marking rest of it. Now, presentation and diagnosis. So there is a triad of prolactinemia, hyperprolactinemia, amenorrhea, galactorrhea, and infertility. Okay, amenorrhea, galactorrhea, and infertility are hallmarks of hyperprolactinemia in women. If it develops before menarche, then there will be primary amenorrhea. More commonly, hyperprolactinemia develops later in life, leads to oligomenorrhea and ultimately amenorrhea. If hyperprolactinemia is sustained, then the vertebral bone mineral density will be reduced because it causes decrease in estrogen levels also. Okay, because of as compared to age match control, particularly when it is associated with pronounced hypoestrogenemia. Galactorrhea is present in up to 80% of hyperprolactinemic women. Although usually bilateral and spontaneous, it may be unilateral and expressed only manually. Usually bilateral and spontaneous, it may be unilateral and expressed manually. Patient may complain of decreased libido, weight gain, mild hirsutism. Right, decreased libido, weight gain, and mild hirsutism. In men with hyperprolactinemia, there will be diminished libido, infertility, visual loss because of optic nerve compression will be the usual presenting symptom. Diminished libido, infertility, and visual loss from the optic nerve compression. Gonadotropin suppression leads to reduced testosterone, impotence, and oligospermia. True galactorrhea is uncommon in men. The disorder's long-standing secondary effects of hypogonadism are evident, like osteopenia, reduced muscle mass, and reduced beard growth. Diagnosis of idiopathic hyperprolactinemia is made by exclusion of the known causes. Some of them may harbor a microadenoma, that is below the MRI sensitivity, that is around 2 mm. Galactorrhea is inappropriate discharge of milk-containing fluid from the breast, considered abnormal if it persists longer than 6 months after childbirth or after discontinuation of breastfeeding. Postpartum galactorrhea associated with amenorrhea is a self-limiting, usually associated with moderately elevated prolactin level. Galactorrhea may occur spontaneously or it may be elicited on nipple pressure. In both men and women, galactorrhea may vary in color and consistency. It may be transparent, milky, or bloody, arise unilaterally or bilaterally. Mammography or ultrasound is dedicated for bloody discharges, particularly from a single nipple, which may be caused by breast cancer. Galactorrhea is commonly associated with hyperprolactinemia caused by any of the conditions. Acromegaly is associated with galactorrhea in 1/3 of patients. Treatment of galactorrhea involves managing of underlying disorder, that is replacing T4 for hypothyroidism, discontinuing medication, and treating prolactinoma. Lab investigation for hyperprolactinemia, basal fasting morning prolactin levels normally less than 20 should be measured. to assess hypersecretion. Both false positive and false negative can come. If the patient is markedly elevated more than 1000, reported results may be falsely lowered because of assay artifacts. Sample dilution is required to measure these values accurately. Okay, so if there are really high prolactin level, the resorted result may be falsely lower because of assay artifact. Let it be not important. Falsely elevated may be caused by aggregation forms of circulating prolactin, which are usually in the biological inactive macroprolactinemia. Hypothyroidism should be excluded. Basically, in investigation, just mentioned that the fasting prolactin, basal fasting prolactin level should be checked, and in investigation you can measure the relevant investigation which you want for these etiologies. Hyperprolactinemia treatment depends on the cause. Regardless of the etiology, treatment should be aimed at normalizing PRL level to elevate the suppressive effect on gonadal function, halt galactorrhea, and provide improve bone mineral density. So basically, dopamine agonists are effective. Okay, if the patient is taking medication known to cause hyperprolactinemia, that drug should be withdrawn. For psychiatric patients who require neuroleptic agent, supervised dose titration or addition of dopamine agonist can help restore the function. However, dopamine agonists worsen the underlying psychiatric condition, especially at high doses. Hyperprolactinemia usually resolved with adequate thyroid hormone replacement in hypothyroid patient and after renal transplantation in patient undergoing dialysis. Right, dissection of